Hi there, it's Kathy Cates and Melissa Hines from the Institute for Pelvic Health.
And you're watching Demystifying the Pelvic Floor, weekly videos providing real and simplified pelvic floor education for your real clinical situations. We've got you covered.
And today we're going to go over a case study of a patient of ours with IC/BPS and how you can incorporate the pelvic floor into your exam.
All right, so today we have a 20-year-old female, G0P0, and she's here to see you in your office for her third visit for burning with urination, frequency, urgency, and pelvic pain. So Urogyne diagnosed her with IC-BPS and levator ani spasm about 6 months ago. She's trying to adhere to the IC diet, and it's somewhat helpful for her. Her urodynamic studies and pelvic ultrasound were unremarkable, and Urogyne referred her to pelvic floor therapy, but there's a very long wait list. And all previous urinary labs have been within normal limits, and her in-house urine dip today is within normal limits. And you've only got 15 or 20 minutes. What are we going to do?
So pertinent ROS, urinary, the past medical history, bowel every day, Bristol stool of 4, no straining. Reproductive, her last period was on July 5th. It's every 28 days. She's unable to insert a tampon. There's some cramping, but not missing class or work because of it. She's sexually active with same-sex partner, able to orgasm with clitoral stimulation, but unable to tolerate finger or sex toy inside.
So no over-the-counter medicines and no prescription medicines. And
social history, she's a sophomore in college and works part-time as babysitter for a lovely family in her apartment building. She's a non-smoker, a social drinker, 1 to 2 glasses of wine per week, but she knows that that's an irritant for her symptoms.
So using a pelvic floor lens, this is why we're taking a deep dive into both her bowel and reproductive and sexual health review of systems, because these are all going to help us to start narrowing down all the possible differentials and, most importantly, the things that we can do when she's in front of us to help her. So no concerns with her vital signs, and things you want to be looking at in your external assessment are documented here. You're looking at the vulva, the labia, the vestibule, and you're commenting on if it's dry or well hydrated. In her case, it's quite dry. She's got mild erythema. And something that's really important for these patients is to look at the actual architecture. And are the labia majora and minora, are they fully intact? Do they go from that top at 12 o'clock all the way down to 6 o'clock? And then when we go internally for our bimanual exam, you're going to actually stop for a moment and think and wait and see, like, wow, that actually does feel quite tender to palpation at her introitus. And you're going to actually palpate the urethra and notice that there's also tenderness to palpation there. And think about what it could mean from a pelvic floor muscle standpoint that it's difficult to insert your index finger farther than your DIP.
And then we've listed ICD-10 codes for you, and then just a general plan. So a big one is diaphragmatic breathing in a supported supine squat. So lying on her back with her knees bent, feet on the wall, doing 10 reps 3 times a day to promote pelvic floor relaxation. And there's actually a great video that we'll pull up in a second to show you the connection between the respiratory diaphragm and the pelvic diaphragm or pelvic floor. Consider vulvar, vestibule, labia moisturizing routine without chemicals of concern. We've listed one here, V-Magic, which is a great one. And then applying that about a dime size amount to that entire vestibule from clitoris to anus. Introduce dilator therapy You always want to start with a small size so you don't traumatize the area that's probably inflamed. If she can only tolerate one index finger, then you probably want to go with a size 1 dilator for her to work on desensitizing the tissue at home. So now we'll pull up the video for you to see. And you can see with breathing out how that respiratory diaphragm goes up. So does the pelvic diaphragm. It recoils up to the belly button. And then as you breathe in, that respiratory diaphragm drops down and that pelvic bowl drops into even more of a bowl shape. And that's the relaxation component that's so important for pelvic floor relaxation. And that's a wrap. Did you like this video? If so, hit like and subscribe. Please share with your colleagues and comment below to let us know your biggest challenges with caring for your patients with IC or BPS.
And subscribe to our email list at instituteforpelvichealth.com to get your free guide, 4 tips for managing that challenging pelvic exam. You also get access to our free weekly pelvic health content.
And be sure to find us on Instagram, Facebook, and LinkedIn, where we're going to post more pelvic health tips. We're also really excited to announce that we have an online course for nurse practitioners and midwives focusing on the pelvic floor that's releasing soon, hopefully September.
Our course will break down the pelvic floor so that you can confidently care for your patients with pelvic floor dysfunction. By simplifying the pelvic floor, we'll improve patient outcomes and your provider experience. Thanks for watching and spreading the word. Let's revolutionize pelvic health, and we'll see you soon. Bye.